Today we're going to talk about ARDS, or Adult Respiratory Distress Syndrome. The objectives for today are explain in your own words what ARDS is, state the causes of ARDS, and explain the assessment and management of ARDS, and also list the treatments or interventions for ARDS. Acute respiratory distress syndrome or adult respiratory distress syndrome. Either terms are accurate, again, depending on which facility you're in. Severe acute lung dysfunction that is associated with a variety of diseases such as pneumonia, shock, and sepsis, and trauma. That's the definition for ARDS. Usually begins in one area, then spreads quickly to both lungs, and the alveoli become damaged. Some collapse and lose their ability to receive O2. With some alveoli collapsed and others filled by fluid, it becomes difficult for the lungs to absorb O2 and get rid of CO2. As the injury continues over the next several days, the lungs fill with inflammatory cells derived from circulating blood and with regenerating lung tissue. Scar tissue forms after about 10 days, and this fibrosis interferes even more with ventilation. So it's an acute situation that has a variety of causes. Some of the causes are physical injuries, such as a severe blow to the chest. Hitting the steering wheel could cause a pulmonary contusion and results in ARDS. I've seen that happen several times. Toxic injuries, such as aspiration and inhalation injuries, aspiration of the gastric content, smoke inhalation, toxic chemicals can cause severe damage to the alveoli, resulting in ARDS. When a body is very sick or injured, some chemical signals are released in the bloodstream, and these cause lung failure as well. Sepsis would be a type of indirect or bloodborne injury, which sepsis is an overwhelming infection that the body can't fight. Trauma differs from physical injury in that trauma affects all areas of the body, and the chemicals are released in response to these injuries. Blood transfusions can cause ARDS as well by neutrophil aggregation in the microvascular areas of the lung, which release proteases and superoxide radicals, resulting in cell injury, which leads to the pulmonary edema and ARDS. So you see that every once in a while. It's called TRALI, T-R-A-L-I, transfusion-related acute lung injury, and again, that's caused by neutrophil aggregation in the microvasculature of the lung. So that is one type of injury that causes ARDS. If it's going to happen, it will happen in the first 1 to 2 hours. High altitude pulmonary edema can also cause ARDS, and this is caused from an increased pressure to the capillary membranes and causes them to burst. It changes the oncotic and hydrostatic pressures and allows fluid to leak into the interstitial space. So all these types of injuries to the lungs can result in ARDS. There's 3 stages of ARDS. 1 is the exudative stage, 2 is a fibroproliferative stage, and 3 is the resolution and recovery. The exudative stage is characterized by accumulation in the alveoli of excessive fluid, protein, and inflammatory cells that have entered the air spaces from the alveolar capillaries. The exudative phase unfolds over the first 2 to 4 days after onset of lung injury. So the exudative phase usually unfolds over the first 2 to 4 days after onset of the lung injury. The fibroproliferative stage characterized by connective tissue and other structural elements in the lungs that proliferate in response to the initial injury. Under a microscope, lung tissue appears densely cellular. Also in this stage, there is a danger of pneumonia, sepsis, and rupture of the lungs, causing leakage of air around the surrounding areas. Then the third and final stage is the resolution and recovery, and during this stage, the lung reorganizes and recovers. Lung function may continue to improve for as long as 6 to 12 months and sometimes longer. We see patients that have had ARDS and they come back a year or 2 later and say their pulmonary function tests still are not normal, that they're still recovering. So it's not unusual for it to take months and even years to recover from ARDS. signs and symptoms of ARDS, shortness of breath at rest, cough, fatigue, abnormal ABGs, abnormal breath sounds, and anxiety. Those are all signs and symptoms that something is not going right in the lungs. Plus, you take a good history of them, so you know that if they've had a chest injury or if they've had an inhalation injury or something, you can always suspect ARDS. Lab and or tests that are used to diagnose ARDS, ABGs usually show hypercapnia and hypoxemia. That's usually. Sometimes you'll see hypocapnia and sometimes you'll see normal CO2. So it just kind of depends on the patient. Other lab is not as useful, but it just helps explain the underlying condition. Chest x-rays certainly reveal characteristic diffuse alveolar interstitial infiltrates in all lung fields. In early cases, the radiology findings may not be fully developed. So it depends what stage the patient is in before you really get a good chest x-ray. Additional localized pulmonary findings may be present if the predisposing condition involves a pulmonary process. So if it was an inhalation injury, you may see that quicker. Chest CT may be helpful in advanced cases, but not necessary for diagnosis. And echo may be helpful to exclude cardiac etiology or pulmonary edema. Sputum should be collected for gram stains and cultures, such as bacterial, fungal, viral, if a pulmonary infection is present. These are best obtained from the lower respiratory tract shortly after the ET tube is placed. Bronchoscopy with bronchoalveolar lavage may be helpful to identify pulmonary infections, but is usually performed in the ICU. They usually want to get a sample right away. A pulmonary artery catheter may be helpful to exclude cardiac causes, but usually is placed in the ICU as well. So these things aren't definitive, but they do help explain the underlying cause. Assessment, ABCDs. We're going to add a D in there for differential diagnosis. Airway, breathing, circulation, differential diagnosis. What do you think some of the differential diagnosis of ARDS is? CHF, pneumonia, pulmonary contusion, and pulmonary edema all need to be considered as differential diagnoses for ARDS. These are some chest x-rays of the ARDS patient. The one on the left is a normal, of course, and then the one on the right is severe ARDS, especially on the right side, which usually it's on both sides, but this one happens to be more prominent on the right side. So that's an excellent chest x-ray. Here's another one of that diffuse ground glass appearance, which is what you'll see in ARDS patients. This is an excellent x-ray of what you would normally see. You can see they've already had a trach placed, so this is probably maybe 10 days post initial diagnosis. You can also see a bronchopleural thickening and this x-ray, which indicates to me that this probably has been going on for a while. Treatment basically is supportive care. There's not a definitive treatment. Vent support may need smaller volumes, higher rates, high PEEP. They also may need antibiotics, vasopressors, anti-anxiety meds, a lot of oxygen, and treat the underlying cause as best as you can. Complications of ARDS, multiple organ failure, resulting from lack of oxygen to the organs. This seems to happen quite frequently. Once they're in ARDS, it seems like all the systems follow. Death, permanent lung disease, oxygen toxicity, barotrauma, and superinfection. All these things are hypoxemia related. Non-survivors usually die from sepsis or multiple organ failure. Survivors usually have a good outcome with minimal, if any, persistent pulmonary symptoms. You just got to give them time. Sometimes it takes years to get their lungs back to semi-normal. Survivors of severe cases may have some degree of pulmonary fibrosis and symptoms of restrictive lung disease. So these patients are really sick. I'm sure you've seen several of them. This is just kind of a review. But the other thing I want you to think about is what's the differences between ARDS and CHF. And the worksheet you're going to do will compare those two. So take a look at that and see if you can think in your head what are the major differences between ARDS and CHF.